This is Dr. Jerry Hesch. I am a physical therapist at Hesch Institute, which is in Aurora, Colorado, and I'm presenting on a pattern named bilateral outflare of the ilium. In this pattern, it appears that the ilium may have migrated posteriorly, either in relationship to the sacrum, or this pattern has altered muscle dynamics such that there is blocked mobility when you try and spring the ilium anterior and laterally along that plane of the ilium, blocked on both sides. And when springing the sacrum, the sacrum appears to be hypermobile and it has a weak recoil. So it has a propensity for springing anteriorly, but not for recoiling. The other thing you find in this pattern, which is a pattern of symmetry, landmarks are symmetrical throughout, but there is that movement aberrancy noted with spring testing. You also note that there's a softening of the sacrotuberous ligament and the sacrospinous ligament. I also have a ligamented model here, and here you can see the long dorsal sacroiliac ligament, and here you can see the sacrotuberous ligament going from the ischial tuberosity to the lower sacrum, and over here you can see the more horizontal sacrospinous ligament. Now when muscles become inhibited, then they allow greater excursion of bony mobility, greater excursion of joint mobility. And we know that there are several muscles that insert on these ligaments. The sacrotuberous muscle has a partial origin on the sacrotuberous ligament. Piriformis muscle has partial origin there. And the biceps femoris hamstring muscle sometimes inserts not only on the ischial tuberosity, but it also inserts partially onto that sacrotuberous ligament. And it could be that these muscles are inhibited, and so their resting tone is decreased, and therefore there is a reduction in tone in the ligaments in which they have a partial origin or insertion on. And whatever reason, the pattern that I named bilateral outflare of the ilium, there is blocked mobility with anterolateral spring testing on each side of the pelvis, on the hemipelvis, and there is increased anterior mobility of the sacrum, but a weak recoil. And so this presents as hypermobility of sacrum, hypomobility of the hemipelvis. And it's very simple to treat, and it's a very rare presentation, but I have seen a couple of folks present with this, and they had a very dramatic response in which they were much more functional after treating this pattern. And I simply lay 2 pieces of foam. This is 2-inch by 4-inch by 8-inch long half moon foam. You could roll up hand towels firmly so that they're 2-inch diameter by 8 inches, and you can make a gentle V, about a 20-degree angle, such that there's no pressure on the sacrum, but there is pressure on the ischium and also on the ilium, gliding the hemipelvis anteriorly. And I do that for 5 minutes, and also instruct them to do that at least once a week for 5 minutes to reinforce the mobility gained. And it might be that these folks are hypermobile with respect to sacral mobility, and that wearing a sacroiliac support either high or worn lower at the level of the trochanters might be helpful to them. And trial and error will indicate which of those levels is more comfortable. There's some very good research on both sides. Research showing us that a pelvic belt worn high is helpful, and there's research in the trauma literature that shows that pelvic belt worn low at the level of the trochanters is very effective and imparts 40% more compression at the pubic joint and at the sacroiliac joints. So the moral of the story is I try it on both levels and let the client decide what is most comfortable. So this concludes my presentation on a bilateral outflare pattern of the pelvis with an anterior glide hypermobility of sacrum. And I hope this is helpful. Thank you.